extracellular or intracellular. Okay. So extracellular are divided into intravascular or interstitial. Okay. Today our topic of discussion is dyselectrolytemia. Last class we have talked about the normal composition. What is a normal composition of plasma, normal composition of intracellular fluid, extracellular fluid. We have discussed about that. Okay. Today we will talk about the abnormality. What is the main composition of the now just tell me what is osmolality? Osmolality একটা ফর্মুলা ম্যাডাম পড়িয়েছিলেন মনে আছে? কি component, at least what are the main major component of osmolality? কি থাকবে বল? কি থাকে মেইনলি? সোডিয়াম। সোডিয়ামটা থাকে আর কি? ব্লাড ইউরিয়া নাইট্রোজেন আর গ্লুকোজ, এই তিনটেই মেইন পার্ট থাকে। ওকে, তো দিস ইজ সোডিয়াম। তাহলে হোয়াট ইজ দ্য মোস্ট কমন extracellular cation? Extracellular, intracellular. Extracellular, which one is more common? Sodium. Or intracellular cation, potassium. Okay. These are the two major electrolytes. I mean, we have to concerned about those two, about these two electrolytes. Their abnormality, higher, lower, all both the abnormalities are very important for our normal physiology. Okay. Sodium. So, what is the normal concentration? 135. Very good. 135 to 145. Okay. Very good. Daily requirement is 2 to 3 milliequivalent per kg body weight, and it is quite higher in preterm, VLBW and preterm, because their kidney is not so matured, so reabsorption is not properly done, so their requirement is slightly higher. The major excretion via renal pathway, and some other extrarenal loss take about through sweating, burn, diarrhea, vomiting. Okay. This point is very important. You have to keep it in mind, especially when we will discuss about the dyselectrolytemia part. This point is very much important, because look at here, it is there is regulation of sodium, and at the same time potassium is also getting regulated via this pathway. Look at this, whenever there is low BP, so low BP means low blood flow to macula densa. So whenever there will be low blood flow to the macula densa, what will happen? There will be RAS activity. What is RAS? System, renin, angiotensin, double A দেয় অনেকে, renin, angiotensin, aldosterone system. Here basically, so there is, whenever there is stimulation, there is generation of angiotensin 2, sorry. There is stimulation of, whenever there is stimulation, there will be angiotensin 2 generation, which causes aldosterone secretion. Now this aldosterone causes sodium, it increases sodium reabsorption and at the same time potassium secretion. So potassium is getting excreted and sodium is being reabsorbed. Okay. Though potassium is not mentioned here, the pathways is same. Just keep it in mind. Okay. So next move to the abnormality part. So what can be the abnormality? It may be less or higher. What is the less? When we will the sodium is less than the normal range, we call it hyponatremia. The terminology is specific. Hyponatremia, and whenever there is this more, hypernatremia. Okay. So what is a hyponatremia? Less than 135 milliequivalent per liter. So what are the causes? Now before going into the causes, just keep it in mind one point. So since sodium is extracellular fluid, extracellular electrolytes, always sodium goes along with water. You cannot exclude water from sodium. So whenever you are considering sodium, you have to consider fluid part also. Okay. So considering fluid part or the water part, the hyponatremia may be of 3 types. Okay, 3 types: hypovolemic hyponatremia, normovolemic and hypervolemic. Whenever we will read about or we will discuss about sodium, just think about one point. Consider consider a glass jar with water and sodium within it. Whenever we will মানে এরকম ভাবে পড়লে কি হবে বলতো, তোর বুঝতে পারবি যে because sodium is always being dissolved in the water in our plasma. Okay, so always consider water along with that. So whenever there is a jar with water and sodium, what can be the abnormality? Considering the hyponatremia, there may be more water, we can add more water, or we can water with sodium can get excreted. That may be another point. Another point may be what? Everything is normal. I mean the volume part is normal, total water part is normal, but sodium, there is abnormality in the sodium. So this thing, so hypovolemia, hypervolemia and normovolemia, these 3 features, these 3 these 3 episodes can occur. Okay, so what is, first we will talk about hypovolemic hyponatremia. Hypovolemic, I mean, so volume is getting exhausted. So what are the pathway? কিভাবে বেরোতে পারে? There are only 2 pathway, renal and extrarenal. Renal is the most common, আমরা পড়লাম আগে, most common renal. So what can be the point? Diuretic use. Diuretic means, diuretic হচ্ছে যেটা বেসিক্যালি diuresis করে, মানে ইউরিনটা বেশি করা, হ্যাঁ সেটা করে diuresis, ঠিক আছে? Diuretic is any medicine which causes diuresis. Osmotic diuresis, osmotic diuresis is what? Whenever there is high osmolality, I mean in case of hyperglycemia. Hyperglycemia, we know that hyperglycemia causes polyuria. So it is basically osmotic diuresis. Okay, so the osmotic diuresis, renal salt wasting syndrome, adrenal insufficiency. Adrenal causes what? Sodium reabsorption. So whenever there is adrenal deficiency, there is less sodium is getting reabsorbed. Okay. Extrarenal loss ki? Whenever there is severe diarrhea, severe vomiting, a burn patient, there is severe dehydration, excessive sweating, all this thing causes loss of sodium along with fluid, okay. There is, in hypovolemia, the sodium is getting exhausted, and at the same time water is getting exhausted more than sodium. So there is hypovolemic hyponatremia. Okay, what is normovolemic hyponatremia? The total volume is normal. What happens in normovolemic hyponatremia? The condition is known as SIADH. That means syndrome of inappropriate antidiuresis. Syndrome of inappropriate antidiuresis. What happens in SIADH, or syndrome of inappropriate antidiuretic hormone secretion? Antidiuretic hormone does what? It causes sodium accumulation. It prevents sodium excretion take বাধা দেয়. It causes sodium accumulation. Whenever the antidiuretic hormone কোথা থেকে secrete হয়? Posterior pituitary. Very good, posterior pituitary. So the hormone is getting secreted from the posterior pituitary, and it acts on the V2 receptor. Okay, ওরা কি যে জলটাকে accumulate করছে. So there is more water accumulation. তাহলে কি হচ্ছে, জলটা সোডিয়ামটা ডিসলভ হয়ে যাচ্ছে. সোডিয়াম ইজ নর্মাল, সোডিয়ামের সাথে নো প্রবলেম ইজ সোডিয়াম, বাট দ্য ওয়াটার কন্টেন্ট ইজ মোর, এক্সট্রা হয়ে যাচ্ছে, ওয়াটার এক্সট্রা হয়ে যাচ্ছে. নর্মাল যে ওয়াটারটা এক্সক্রিশন হওয়ার কথা ছিল সেটা হচ্ছে না, ওয়াটার ইজ বিং অ্যাকিউমুলেটেড. তাহলে সোডিয়ামটা কম্পারেটিভলি বেশি কম হয়ে যাচ্ছে. এটা থেকে বেসিক্যালি কি হয়, there is, why this abnormality? There is a whenever there is insult to the brain, either maybe brain, like any kind of brain trauma, meningitis, tumor. Look at the point, all the points are mentioned. Any system, meningitis, encephalitis, tumor. Okay, in the direct insult to the brain, or insult, there may be indirect insult via pulmonary route. Why pulmonary route? There, in case of pneumonia, ARDS, severe asthma, in those cases also indirect insult causes inappropriate excessive antidiuretic hormone secretion. The normal threshold is getting lowered, okay, the normal threshold is lower. The osmolality, whenever the antidiuretic hormone কখন secrete করবে, যখন জলের প্রয়োজনটা বাড়বে, that means whenever there will be high osmolality. What is the normal osmolality range? 285 to 295. তো normally যখন ওর থেকে বেশি হয়ে যাবে তখন it should be secreted, but here the threshold is low. At low osmolality, ADH is getting secreted. So it is inappropriate, which should not be normal, okay. So that's why we are calling it as inappropriate, syndrome of inappropriate antidiuresis. Some drugs are there that causes like cyclophosphamide, vincristine. You have to remember all the points, okay. In post-operative phases, all these cases, there will be abnormal secretion of ADH hormone, okay. Another point is what? Hypervolemic. Hypervolemic. So water cannot getting excreted properly either, or the water content is more than the capacity of kidney. ঠিক আছে, কি হতে পারে? Kidney, consider kidney like any kind of AKI or chronic kidney disease, nephrotic syndrome, congestive cardiac heart failure, cirrhosis. In all those cases, there is hypervolemic hyponatremia. So water cannot get excreted properly, okay. Among all the points, what is the most common cause? Most common cause is the SIADH. Look, osmostat is reset inappropriately. Increase ADH secretion at lower threshold. Low serum osmolality, less than 275. Now, whenever there is a low, so water is getting accumulated. So less water is getting excreted through urine. So there is urine osmolality is high. Urine osmolality is getting high, okay, with high urine sodium. So these are the causes of hyponatremia. Now we will look about manifestations. Now see, hyponatremia, hypernatremia, all these points are very important, very important. You will get patient in, even if you can skip the topic in your exam, but you cannot skip in your clinical practice time, okay. You will get any patient with, especially the critical care patient, most of the patient there will be dyselectrolytemia, okay. So these cases are more commonly hospitalized patient. No patient will come to you with the sodium, doctor, I have done sodium and it has come less, kindly treat me. No patient will come to you. There must be some manifestations and the patient will be hospitalized patient in all cases, okay. So there must be some and the manifestations are very that may be very critical. Symptoms, now less than 135 is hyponatremia, but 130 to 135 the body can manage, or there may be less symptom. But whenever it is getting less than 130 or especially 125, there will be symptom, okay. So in the initial period there may not be any symptom, but whenever there will be less than this cutoff, the symptom will appear and the symptom is that can be very significant. Initial manifestation, look, only headache, nausea, vomiting, lethargy, confusional state. But look at the advanced manifestation, seizure, coma, raised ICT, okay. All these features are very critical condition. There may be uncommonly arrhythmia or myocardial infarction also. Now whenever we are discussing hyponatremia, you have to keep it in mind about few things. What is cytotoxic cerebral edema? Why? See, look at the manifestation, most of the symptoms are regarding CNS. So there is some pathology occurring in the CNS, cranial nervous system, okay. what happens? There is low sodium or the water content is more. So, there is osmolality is low. At the same, what happens in that cases? There is intracellular osmolality is quite higher comparatively compared to the extracellular fluid, because there is sodium is less. So, what happens in that case? Good morning, sir. আজকে টিচারের সংখ্যা বেশি, একজন স্টুডেন্ট। So, there is fluid there will be influx of water into the intracellular space, which causes what? Cellular edema. Cell will swollen up. Okay, cell will swollen up. This is the main pathology of the cytotoxic cerebral edema. Okay, so whenever the neurons are getting swollen, so there is raised ICT, intracranial tension, because we know what? The brain volume is fixed and the content within the brain is fixed. Any small drop of blood, a small drop of any water, that causes raised tension. Okay. So, there is raised intracranial tension that ultimately may cause herniation, brain ischemia, because whenever there will be high pressure, the blood flow will be hampered. That may cause brain ischemia, ultimately herniation or death. Okay. The risk factor for hyponatremic encephalopathies, these are the factors: young age, hypoxemia, neurological, underlying previous any neurological disease. In those cases, the manifestations will be significant and quite earlier. Okay. Next, the management part. Now, how to manage? In case of managing hyponatremia is very critical also. You have to go very cautious. You have to consider few points in case of treating the hyponatremia. First, look at whether it is acute onset or chronic onset. Acute onset means less than 48 hours, chronic means more than 48 hours. In case of acute onset, you have to treat, you have to recognize the case, you have to treat early. But in case of chronic hyponatremia, you have to go very gradually, because slightly if you hurry up, that may cause in that intracellular cytotoxic cerebral edema. Keep that pathology in your mind. What? That there is another point I just missed. Cytotoxic cerebral edema, whenever there is a difference in osmolality, what happens? There is some generation of intracellular osmolyte, which gets in the chronic hyponatremia cases. There is generation of some osmolytes. So this thing happens. In that case, if you hurry up, in that case those osmolyte can get out of the cell, and that may interfere in our treatment. So, chronic hyponatremia treatment, you have to go very slowly. Okay. And one important point is the volume status. Whenever we have discussed about the cause, there was one point, hypovolemic hyponatremia. Whenever there will be hypovolemia, you have to correct the volume status very first before correcting the difference, the deficit. Okay, sodium deficit. You have to first you have to correct the volume status. That I have been taught in the last class also. Whenever you will treat the hypovolemia, shock, the treatment of shock with the normal saline bolus. Okay, just that point. Fluid restriction alone or in combination with diuretics in case of what? Volume expanded, I mean hypervolemia or normovolemia in SIADH. In those cases, we restrict the fluid, and at the same time if required, diuretics may be given. Okay. Now, approach to hyponatremia. See, I have already told about that you will not get any patient coming to you stating, doctor, I have hyponatremia. The patient will always be admitted patient. So, there should be some clinical background. You have to correlate your blood report with the clinical condition also. Okay, clinical condition. Whenever there is, first look at whether patient is dehydrated or not. If there is dehydration, the patient is in shock, volume normal saline bolus, go for that first. If the hydration status is, there is no dehydration, then look for whether the hydration status is normal or more, I mean whether there is edema present or not. Okay. If edema is present, then we have to treat separately, and if edema is not present, we can consider also that. So, we should consider that point also. Now, so there is some clinical background. At the same time, sodium is less, sodium is 135. What you have to look for, you have to look for other few things also, like serum osmolality, plasma osmolality you have to look very fast after sodium. Okay. Another thing is urine osmolality, another thing urine spot sodium. Then only we can correlate whether the sodium is getting or whether the what about the water. So, to consider all those things, to reach our diagnosis, we have to consider all those points. Okay. So, whenever there is sodium is less than 135, okay, then look for plasma osmolality. Plasma osmolality is less. Then look for, so there is some water content is more, okay, in the body serum. Then urine osmolality is more than 100. That means urine osmolality, so water is being accumulated, okay, watering is being accumulated. These points we will discuss later, this part and this part we will discuss later. Okay. Whenever there is, so water is getting accumulated. Now, the extravascular fluid volume status. Now, we have to consider with the correlate with the clinical feature. Look, whenever there is hypovolemia, always first consider the hypovolemic status. Whenever there is hypovolemia and urine spot sodium is less than 20 milliequivalent per liter, that means there is no problem with kidney. The kidney is normal, reabsorption is occurring normally. Okay. So, there must be some problem in extrarenal feature. There may be vomiting, diarrhea, burn, excessive sweating, all these things. But if the urine spot sodium is more than 20 milliequivalent per liter, so there must be some excessive renal loss. Diuresis use, renal tubulopathy, cerebral salt wasting. Okay. Cerebral salt wasting is a separate thing, actually you have to know it separately. What happens in cerebral salt wasting, there is brain insult and that causes some natriuretic peptide generation, which enhances sodium. You have patient symptom, there may be confusion. You see, I have told you the patient will be most of the cases ICU patient. In ICU patient, the mental status is very important. Whenever you go in the morning, you have entered the ICU, you have examining your patient, first look at the orientation, mental status. You have to look for the mental status. This is very important point. Whenever there is some alteration in the mental status, the previous day the patient was better, but today you are looking that the patient is quite disoriented, or the patient is complaining that I have in non-ICU patient, if the mental status is normal, the patient can say, amar kichu mone porche na, kemon ekta mathata bhar bhar lagje, eta confusional state, or there may be seizure in advanced. We have seen the in advanced manifestation, seizure, coma, sudden ekta mental status deteriorate koreche. Think about your hyponatremia, always think about hyponatremia. Do blood gas, get your sodium report at your hand and go for the approach. What is happening? Okay. Now, the point, this is about hypovolemic hyponatremia. Now, whenever there is euvolemic, hydration status is normal, but urine spot sodium is more than 20 milliequivalent per liter. So, there is what it happens in SIADH, okay, SIADH, adrenal insufficiency, hypothyroidism. Adrenal insufficiency means the adrenal is not deficiency of adrenal hormone, and that causes what? Less sodium reabsorption, less sodium reabsorption. তার জন্য ইউরিনে সোডিয়ামটা বেড়ে যাচ্ছে, but volume status is normal. Okay. Now regarding this hypervolemic status. Hypervolemic status, that means there is edema. You are looking that the patient is swollen, facial puffiness, there is edema, dependent edema, all these things are there, and you have got sodium report as a less than 20 milliequivalent. In that cases RAS activity is high, because in that what happens? Congestive cardiac failure, nephrotic syndrome, liver failure. Okay. So, this is about the whenever there will be hyponatremia, at the same time low osmolality and the sodium urine osmolality is high. What happens in case of urine osmolality is more less than 100 milliosmol. So, water is getting exhausted along with the sodium, water is also getting exhausted. In what cases? Primary polydipsia. Primary polydipsia means বেশি জল খাচ্ছে বা ইউরিন সবই ঠিক আছে, কিন্তু বেশি কোনো কারণে বেশি জল খাচ্ছে, বেশি ইউরিন হচ্ছে, সোডিয়ামও বের হচ্ছে, ইউরিন ওয়াটারও বেরিয়ে যাচ্ছে, ঠিক আছে, primary polydipsia. Another point is there, that is whenever there will be high osmolality may be higher than normal 295. This is a relative case. Basically, it is not a true hyponatremia. There is, so it is called pseudo hyponatremia. In your jar, that water with sodium, suppose you have adding some other things. You have added some fat, you have added some protein, you have added some sugar. That causes that raising the osmolality. But the net content of sodium is what? It is normal. So, there is relative hyponatremia. Relative. So, that's why it is called pseudo hyponatremia. Pseudo hyponatremia. Okay. So, this is about the approach. You have to approach the patient. You have to approach the case to reach your diagnosis. Okay. Now, we have reached our diagnosis. It may be whatever we have got, then we will treat it accordingly. Now, this is a treatment of management of acute symptomatic hyponatremia. This picture is taken from Ghai only. Okay. First look, hemodynamic instability is there, normal saline bolus. But if the volume status is normal, but the symptomatic hyponatremia less than 125, go for acute case. This is acute. In acute case, you have to give bolus. 3% sodium NaCl bolus, but that is also very gradually. Look, 3 to 5 ml per kg, 3% NaCl over 1 hour, or 2 ml per kg over 20 minutes, Okay. And at the same time, you have to look for sodium, whether the sodium is getting corrected or not. Do sodium every 1 to 2 hours. Whenever the one bolus is completed, do another sodium. Look whether there is improvement happening or not. Okay. If there is improvement, then we will look for what? There is increase in sodium and resolution of symptom. The patient will be, there will be symptomatic improvement. Then you will understand that my treatment is working. Then whenever the symptom is improved, then stop 3% NaCl infusion. But if not improved and the symptom is persisting, you can go for other bolus also. Okay. So, this is a treatment of acute symptomatic hyponatremia. What about the chronic or asymptomatic hyponatremia? You have to treat the underlying cause. You have reached your diagnosis from the approach from the previous slide. So, you have reached your diagnosis, but the symptom but the sodium is suppose 125. Whenever the less than 130, chronic hyponatremia we have to treat. We have to give sodium supplement. 3%, we give 3% sodium supplements. Okay. So, there is a particular formula according to the body weight, that is 131. We consider 130 as a standard, because we have to go gradual, very slowly, we have to go very slowly. So, do not take 135 as the target height. Your target should be 130. Okay, 130. So, 130 and your sodium, the report you are getting, your patient's sodium, get the difference, multiply with this is a standard and the body weight. So, This is the sodium deficit you have to provide. This is the sodium deficit you have to provide. Now, see, whenever you will work in practically, actually practically the solution we have in our hand like 3% NaCl or NS, these are actually volume, that is ml, we have milliliter in number. Okay, so we have to convert your unit. Okay, they don't and whenever you will work practically, in that case তখন আমরা এটা বলতে পারবো যে অ্যাকচুয়ালি কতটা ml দিতে হবে, কতটা কি দিতে হবে, বাট দ্য ডেফিসিট ইজ দিস থিং, deficit is this thing. Suppose 3% NaCl and normal saline, though those concentration is different. In normal saline it is 154 milliequivalent per liter, but in 3% NaCl it is 3% extra, in 3 times around 500. Okay, so considering the fluid you will give, then calculate the actual volume, actual net volume what you will give to the patient. But the formula is this. See, look, the next point is rise of serum sodium should not exceed 0.3 to 0.5 milliequivalent per hour. Whatever may be the report, whatever may be the sodium concentration of your patient, you cannot correct more than 12 milliequivalent in 24 hours. Not more than 12 milliequivalent. You have gradually amake jete hobe. Chronic, because see, whenever you will give 3% NaCl, suppose you are giving extra amount of 3% NaCl to your patient. So there was initially what? Extracellular fluid was hypoosmolar and the cellular osmolality beshi chilo. Now suddenly you have provided 3% NaCl. So your extracellular fluid osmolality ta bere jacche, suddenly bere jacche. So তখন কি হবে, ওয়াটার মানে ইন্ট্রাসেলুলার যে ওয়াটার সেটা বেরিয়ে আসবে, সঙ্গে সঙ্গে কী করবে, তোর সেলটা শ্রিঙ্কেজ হয়ে যাবে, সেলটা শ্রিঙ্কেজ হয়ে যাবে। সেই জন্য আমাদের খুব গ্র্যাজুয়ালি যেতে হবে। ক্রনিকে কেন, ক্রনিক আর একটা জিনিস বললাম, ওই যে অসমোলাইট কিছু তৈরি হয়, তো অসমোলাইট তৈরি হয়ে ও সেটাকে জলের বাইরে বের করছিল ক্রনিক কেসে, মানে যখন ও টাইম পেয়েছে আস্তে আস্তে অ্যাডাপ্টেশন করছে। অসমোলাইটগুলো এবার অসমোলাইটগুলো বাইরে আসে, দিয়ে ও দুটোর অসমোলাইটিকে মেনটেন করার চেষ্টা করছে, বাট সাডেনলি ইউ আর গিভিং 3% NaCl, তো এক্সট্রাসেলুলার ফ্লুইডের অসমোলাইটি আরও বেড়ে যাচ্ছে, তখন কি হবে, তখন হচ্ছে তোর ওই সেল তোর মানে সেলটা থেকে বেরিয়ে আসবে, জলটা পুরো বেরিয়ে আসবে, আরও সেল শ্রিঙ্কেজ হয়ে যাবে, সেখান থেকে আরও ড্যামেজ হয়ে যেতে পারে। সেই জন্য ক্রনিক হাইপোনাট্রিমিয়া ইউ হ্যাভ টু গো very gradually. ঠিক আছে? In case of hypovolemic, that is sodium deficit estimated is given as normal saline. যখনই whenever the patient is awake, go for oral fluid. ইউজুয়ালি দেখা যায় ওই মানে অ্যাওয়েক স্টেটে পেশেন্টরা ওই 130 to 135 এর মধ্যে থাকে। যখনই 130 নিচে চলে আসে তখনই আস্তে আস্তে মেন্টাল স্টেটাসও ডিটোরিয়েট করতে থাকে, তখন দ্য পেশেন্ট উইল নট বি ইন কন্ডিশন টু টেক দ্য ফ্লুইড ওরালি। ঠিক আছে? ইন SIADH we have told you have to do fluid restriction. Just do fluid restriction. If fluid restriction is not working, then only go for furosemide, other thing. And hypervolemic state, that means congestive cardiac failure, liver failure, when the water content is more, edema. দেখবি যখনই ক্লিনিক্সে ক্লাসে গেলে ইডিমাটাস পেশেন্টকে ফ্লুইড দেওয়া হয় না, ফ্লুইড রেস্ট্রিক্ট করা হয়, ওদেরকে বলা হয় যে এতটার বেশি জল খাবে না। কিডনি ডিজিজের পেশেন্টকে, সিকেডির পেশেন্টকে বলা হয় যে এতটার বেশি জল খাবে না, সো ইউ হ্যাভ টু রেস্ট্রিক্ট দ্য ফ্লুইড। ঠিক আছে? আর সেরিব্রাল সল্ট ওয়েস্টিং সিনড্রোমে আমাদের স্টেরয়েড দেওয়া হয়, কর্টিকোস্টেরয়েড, যখন ওটা ডিটেলে জানবি তখন বুঝতে পারবি ওর মেকানিজম অফ অ্যাকশন। ঠিক আছে? সো দিস ইজ অল অ্যাবাউট দ্য hyponatremia. Hyponatremia is more serious than hypernatremia, but still hypernatremia is also very significant. This can also cause your life at risk. Okay, so sodium more than 145, we call it hypernatremia. Okay, look at the causes. Now there is sodium excess. So either there may be you have added in your jar, normal jar, you have added sodium in extra, or you have taken out the water part. you have taken out the water part. What happens in either there may be pure water loss, শুধু জলটা বেরিয়ে যাচ্ছে, diabetes insipidus, inadequate breastfeeding, insensible loss, এগুলোতে জল বেশি করে বেরিয়ে যাবে। হাইপোটোনিক ফ্লুইড লস, আবার মানে সেখানে কিছুটা সলিউট বেরোচ্ছে, ওয়াটারও বেরোচ্ছে, সোডিয়াম অলসো গেটিং এক্সক্রিটেড। রেনাল লুপ ডায়োরেটিক্স, পোস্ট অবস্ট্রাকটিভ ডায়োরেসিস, এটিএন এর ফার্স্ট ফেজে মানে কিডনি ডিজিজগুলো না অনেক কিছু ফেজ হয়, and you have to treat the cases accordingly. So according to the phase there may be some changes. So in ATN এর এই polyuric phase এ, polyuria মানে বেশি করে ইউরিন বেরিয়ে যাচ্ছে, so there is water getting exhausted. Vomiting, nasogastric drainage, diarrhea, lactulose সেখানেও in that case what in this case water is getting exhausted more rather than sodium, so sodium concentration is comparatively high. Or sodium extra, you are giving sodium extra, either the patient is taking some more amount of salt in excess, or some iatrogenic cause. Most common cause is iatrogenic cause. Okay, in you are giving sodium bicarbonate in your some critical care unit, you are treating a patient with acidosis with sodium-bicarb, that may cause your hypernatremia. So these are the causes of hypertonic feed, boiled skimmed milk, ingestion of sodium chloride, and Cushing syndrome primary hyperaldosteronism, মানে বেশি বেশি করে সোডিয়াম রিঅ্যাবসর্ব হচ্ছে, তাহলে সোডিয়ামটা আইদার খাচ্ছে কোনো না কোনোভাবে বডিতে এক্সেস যাচ্ছে, আর জল বেরিয়ে যাচ্ছে, দিস কজেস হাইপারন্যাট্রিমিয়া। হাইপারন্যাট্রিমিয়া ম্যানিফেস্টেশনস খুব আলাদা কিছু না, এখানে ওই লেথার্জি, মেন্টাল চেঞ্জ স্টেটাস হবে, যে কোমা হতে পারে, কনভালশন হতে পারে, বাট হিয়ার ওয়ান পয়েন্ট ইজ ইম্পর্টেন্ট, দের ইজ চান্স অফ হাইপারকোয়াগুলেবল স্টেট। Hypercoagulable state কেন হচ্ছে, water content is less, so there will be blood flow will be hampered, so there is a hypercoagulable state. Okay, acute hypernatremia or and gradually developing hypernatremia. Look here, the mechanism is there is acute hypernatremia, suddenly suddenly your extracellular osmolality is getting higher, so there is, যেটা আমরা আগে ওখানে ট্রিটমেন্টের ক্ষেত্রে বললাম, এখানে আমাদের এটাই হচ্ছে প্যাথোলজি, there is shrinkage of brain, shrinkage of neurons, water is getting out of the cell, out of the neurons, and there is shrinkage of brain that causes tearing of meningeal vessels, এখানে কিন্তু হ্যামারেজ হতে পারে, মানে ওখানে যে though it is a hypercoagulable state, but this mechanism, the acute hypernatremia, may cause hemorrhage due to tearing of the meningeal vessel. So look, this is a very critical portion. All these electrolytemias are very critical. You cannot go very simply in those cases. Gradually developing hypernatremia, adaptation occurs by movement of electrolytes into the cell and generation of intracellular osmolyte তৈরি হয়ে যাবে এখানে, যখন there will be time adaptation, মানে এটা বডির নিজের adaptation, ঠিক আছে। ম্যানেজমেন্ট, দেখ ম্যানেজমেন্ট ইন কেস অফ হাইপারনাট্রিমিয়া ম্যানেজমেন্ট, just keep in your mind few principle that in whenever there is volume status is abnormal, volume status you have to restore first. See, in every case first you have to look at the hydration status. If there is dehydration, you have to give bolus, normal saline bolus. These are in very first cases, just look at the hydration status of the patient, then go for other thing. Hypernatremia treatment কিন্তু আরো গ্র্যাজুয়ালি যেতে হবে, আরো গ্র্যাজুয়ালি, দিস ইজ আ ফিক্সড পয়েন্ট করা আছে, ফিক্সড টাইম, কখন কতটা বেশি হচ্ছে, ডিপেন্ডিং অন দ্যাট আওয়ার সেরাম সোডিয়াম, we have to keep our time of management within that period, not less than that, never less than that, ঠিক আছে। Whenever there is up to 157, 24 hours, 158 to 170, 48, 170 to 183, 72 hours, 185 to 196, 84 hours. See, whenever gradually the number is going up, our time requirement is getting higher. বেশি যত খারাপ হবে তত আমাদের তত গ্র্যাজুয়ালি যেতে হবে, ঠিক আছে। আরেকটা হচ্ছে যেটা তোর ইম্পর্টেন্ট পয়েন্ট হচ্ছে হাইপারনেট্রিমিয়াতে আমাদের ডেফিসিট দেখা হয়। Deficit মানে water deficit, there is water deficit. We are from the causes we have got there is water content is less, sodium comparative to the sodium water content is less, so you have to provide this deficit. There is a calculation in GHI, it is made, there is some particular formulas are there also, but in GHI for your standard just keep it in mind. The deficit therapy is how to calculate the deficit. It is 3 ml per kg per milli equivalent liter increase of sodium above 145, মানে 145 এর ধর 155 আছে, তাহলে আমাকে কত ডেফিসিট দিতে হবে 3 ml আর 10 কেজির বাচ্চা, সো 3 ml per kg into 10 into 10, এইটা আমাকে টোটাল ডেফিসিট দিতে হবে এই পার্টিকুলার টাইম পিরিয়ডের মধ্যে, ঠিক আছে। আর অ্যাভাব 145 টু এটা হচ্ছে ধর যখন whenever there will be sodium more than 170 ওপরে গেলে আমরা 3 ml এ করে দেবো, আর যদি 145 থেকে 170 এর মধ্যে থাকে তাহলে 3 এর জায়গায় 4 হবে, ঠিক আছে। বাড়ি গিয়ে বইটা পড়বি, তাহলে মানে এই জিনিসগুলো যত পড়বি যত হাতে কাজ করবি তত শিখবি, এগুলো শুধু মনে রাখা ক্যালকুলেশনের ব্যাপার, তো যত করবি তত শিখবি। সো এইটা হচ্ছে ডেফিসিট ক্যালকুলেট করতে হবে, আর ডেফিসিট এই পার্টিকুলার টাইমে দিতে হবে। এবং আরেকটা জিনিস কি দেওয়া হয় সাধারণত আইসোটনিক ফ্লুইড, ডোন্ট গিভ ফ্রি ওয়াটার, NS বা in maximum n/2, NS by maximum n/2 of this, not মানে এর থেকে লো অসমোলার ফ্লুইড আমরা দেব না, ঠিক আছে। ফ্লুইড রেটটা অনেক বেশি, মেনটেনেন্স ফ্লুইডটা আমাদের বেশি দিতে হয়, বিকজ দের ইজ ডিহাইড্রেটিং স্টেট, সো উই হ্যাভ টু মেনটেনেন্স ফ্লুইডটা আমাদের একটু বাড়িয়ে রাখতে হয়, ঠিক আছে। এখানেও সোডিয়ামও আমাকে সেম, শুড নট ফল বাই মোর দ্যান 0.5 মিলি ইকুইভ্যালেন্ট পার লিটার পার আওয়ার, সেম ওখানেও আমাকে 0.5 এ যেতে হচ্ছে। এটা তোকে মাথায় রাখতে হবে, 0.5 এর বেশি আমি চেঞ্জ কখনো হতে দেবো না, 0.5 এর বেশি চেঞ্জ আমি মানে 1 আওয়ারে 0.5 এর বেশি আমি চেঞ্জ হতে দেবো না, ঠিক আছে। আর বাকি তো ট্রিটমেন্ট করতে হবে, বাকি তো অ্যাডজাস্ট ফ্লুইড অন দ্য বেসিস অফ ক্লিনিক্যাল স্টেটাস, মানে প্রত্যেক দিন এই যে আমাদের কাছে ধর এই 4 দিন টাইম দিয়ে দিয়েছে, এবার তোর তো রোজই কিছু না কিছু ইমপ্রুভমেন্ট হচ্ছে, তোকে টাইমটা শুরু করতে হবে এরকম হবে, মানে তোর ফ্লুইডের রেটটা চেঞ্জ হবে। প্রথমে যা ফ্লুইড রেট ছিল ধর 24 আওয়ার্স পরে তোর কিছুটা তো ইমপ্রুভমেন্ট হয়েছে, তখন তুই নতুন করে ক্যালকুলেট করবি, মানে আগের ক্যালকুলেশন মানে আমাকে 4 দিন ধরে ওই একই রেটে ফ্লুইড দিতে হবে, ইট ইজ নট দ্যাট। Calculate your fluid daily, so keep all this principle in your mind, ঠিক আছে। হ্যাঁ, রিপ্লেসিং অনগোয়িং লস, ওটা তো দেখতে হবে, ডায়রিয়া ভমিটিং যেগুলো হচ্ছে সেগুলো, যে লসটা হচ্ছে সেটা তো আমাকে সেই লসটা দিতে হবে, মানে সেটা আমাকে রিপ্লেস করতে হবে। So ঠিক আছে, this is about all the hyponatremia and hypernatremia. These are actually very huge topic, conceptual topic, you have to make your concept clear.